Good morning, everyone. Welcome to Trio Maryland's October meeting. I am Marty Marin, and this is my wife, Michelle, and we manage Trio Maryland. We'd like to welcome all of our members and our guests this morning. And we have a very special guest speaker today, Dr. Dorry Segev of Johns Hopkins Hospital. And today's meeting is on a topic that we all have so many questions about: transplantation and COVID-19 vaccines. Just wanted to also let you know that our next meeting will be November 13th. And the topic for that meeting is going to be writing your donor family. And now I will introduce Michelle, who will introduce our speaker today.
Hi, good morning. Sorry for that interruption. Today's speaker is Dr. Dorry Segev of Johns Hopkins Hospital, and he's here to talk about transplantation and COVID-19 vaccines, something everyone's been asking about. A little bit about Dr. Segev. He is the Marjorie K. and Thomas Perzefsky Professor of Surgery and Epidemiology. He's also the Associate Vice Chair of Surgery at Johns Hopkins University. He is the founder and director of Epidemiology Research Group in organ transplantation, the largest and most prolific group of its kind in the world. Dr. Segev was the first to demonstrate the survival benefit of incompatible kidney transplantation across the US. And he is responsible for the first HIV to HIV transplants in the United States. Dr. Segev has published nearly 500 peer-reviewed research articles and over 150 in the American Journal of Transplantation. His work has directly influenced policy, including 2 congressional bills, the Norwood Act for Kidney Exchange and the HOPE Act for HIV to HIV transplants. And he is regularly featured in widely read media, including Time Magazine, the Wall Street Journal, and the New York Times. And we are very pleased and very honored to have Dr. Dorry Segev here today to address our group. And please welcome Dr. Segev. Thank you, and I'll turn it over to you.
Thanks for your kind introduction. It's a pleasure to spend an hour with you all this morning talking about a topic that we've spent the last, I guess, 9 months, 10 months at this point thinking about and doing research on and talking with media and talking with you know, the national extent of transplant patients about these issues. And I'm happy to talk with you all about it a little bit and answer some questions that you might have as well. I was asked to prepare a formal lecture, so I've prepared about a 30-ish minute formal presentation of the science and a little bit of the story of how we've learned to understand this science. And then I have left lots of time for Q&A, and I know that you all have lots of questions. I will admit that we, as doctors and epidemiologists, also have lots of questions. So I will do my best to give you things that we have answers for, and to give you a sense of how we think about things for things we don't have answers for. So let's dive in a little bit and talk about the vaccines and the implications for transplant patients. Before I show you any data, I just wanted to acknowledge my research group, ERGOT, the Epidemiology Research Group in Organ Transplantation, and all of the folks you see on this slide have put a tremendous amount of work into studying vaccines in thousands of transplant patients in the last year, both in terms of clinical research and basic science immunology research as well. So I just wanted to acknowledge them up front. And when I show you some data, I will show you the picture of the lead scientist who came up with those findings as well, so that you get to sort of see who our team is and link some of the faces to some of the data. The whole transplant community has been profoundly impacted by this pandemic for the last almost 2 years. And as you all know, as we know, transplant recipients in general have a higher have a higher risk of acquiring basically any disease, let alone this virus, and have generally a higher prevalence of comorbidities, which means higher risk of morbidity and mortality from whatever infectious diseases happen to be around. More early mortality in transplant patients in the COVID pandemic was very scary and very sad. And, when the vaccines came around in December, there was a lot of excitement that this could be sort of the miracle that makes everything better. Unfortunately, patients who were on immunosuppression medication were excluded from the big randomized trials that Moderna, Pfizer, J&J did to prove the efficacy of their vaccine, which is, important and, realistic, because if you're going to do a trial of 30,000 patients that you want to generalize to 350 million people living in the United States, you have to be selective about who is going to be involved in those trials. But sadly, what that means is that transplant patients were not included in these trials. We know that to get a response to a vaccine, you need an immune system. So a vaccine response basically is an immune response. And in general, because immune responses are purposefully suppressed in transplant patients to prevent the immune response of rejection, we also generally reduce the immune response of vaccines. And in general, across all vaccines, transplant patients generally have lower response. And so when the COVID vaccine came out, particularly the new mRNA-based platform, which had never been used in anybody, let alone in transplant patients, we wanted to understand as quickly as we possibly could the safety and then the immunogenicity. And when I say immunogenicity, what I mean is how much of an immune response can a transplant patient mount to these vaccines. The first results that we were able to, the results I'm giving you come from a national study of several thousand transplant patients across the country that we recruited through social media and other electronic means, and who were all very generous with their time and their efforts, and their providing us blood after getting vaccinated, and really became sort of part of the scientific team that we were running through Hopkins. But really our scientific team includes everybody who participated in our studies. And the first things that we were able to report were safety and reactogenicity, meaning sort of early side effects from the vaccine. Because the first worry, if you're a transplant patient in December and you're being offered the vaccine, you want to make sure that it's safe to take the vaccine. There is a risk that vaccines will activate the immune system and then harm your transplanted organ, and nobody wants that. And people wanted to understand what symptoms they would be expecting if they got vaccinated, et cetera. And these data that you're looking at are the reactogenicity of people who got both doses of the vaccine. This was in 742 patients. We saw really no harmful impact on the transplanted organ. There was only one report of an acute rejection sometime after a second dose. But if you look at any group of 742 transplant patients, you would expect at least one rejection to occur during the several months that you're following them. So this was not surprising. This was not attributable to the vaccine itself. And I think with these data, and then similar data from the Israelis and the French group and the Canadians and other groups in the United States, it was pretty clear that the vaccines are safe in transplant patients, will cause side effects just like they cause in people who are not transplant patients. I've gotten the vaccine myself, and I'm well aware of the side effects that it can cause, but that, they are considered safe for transplant patients. And that was really important early on, and remains really important as we think about additional doses and things like that. In March, we had data on 436 transplant patients who got their first dose of the mRNA vaccine. And already then it was pretty clear that there was going to be an issue with vaccines and COVID in transplant patients. And we called this paper the Houston We Have a Problem paper, because only of transplant patients who got their first dose of the mRNA vaccine, only 19% of them had any detectable antibody whatsoever in response to that first dose. And this is in stark contrast to the two big randomized trials, the Pfizer and the Moderna trials, where 100% of people with normal immune systems, shall we say, had antibody detectable after their first dose. So if you're immunocompetent, if you have a fully functional immune system, 100% of people had detectable antibody after the first dose. Among transplant patients, fewer than 20%. So obviously, not just a small problem, but a big problem for transplant patients. And we published this in JAMA, the highest impact medical journal in the world, in the hopes that we could get the word out to transplant patients that, hey, look, getting vaccinated is important and is safe, but be careful out there. You are not nearly as protected as non-transplant patients are. And this was in particular impactful for people taking anti-metabolites like mycophenolate. Cellcept would be the brand name for that. Only 10% of people who took an anti-metabolite had any detectable antibody whatsoever. Older patients seem to have less antibody response, but only by a small amount. People who were further out from their transplant had better antibody responses, presumably because in general their immunosuppression was less than fresh transplanted people. And it seemed that the Moderna vaccine was better at getting an antibody response in transplant patients than the Pfizer vaccine by a pretty reasonable margin. Obviously, in March, when we sent that to JAMA, they said, yes, you are right that this is important for this to come out, but please, call us back when you have dose 2 data. And by May, we had dose 2 data published in 658 patients. And now we have that on more than 1,000. And things did get better, as one might have expected. We went from around 20% who had detectable antibody to now around 57% who had detectable antibody. But two really important things came from that. One is that even after 2 full dose mRNA vaccine series, 43% of transplant patients had no detectable antibody. It was almost like we didn't even give them the vaccine, which was obviously very scary. And then even among the 57% who did have detectable antibodies, now we started looking at the level of antibody, and it turned out that they had less antibody in general than people with normal immune systems. And here you can see these are 2 different testing platforms that you use. That's why they're kind of they're split up like this. But you can see that the blue lines, these are the people who had detectable antibody after their first dose, and all of them rose quite high to very nice levels of antibody after their second dose. The pink dots are people who had no antibody detectable after their first dose. Remember, that's 80% of the transplant population. And even after the second dose, a number of them, a high proportion of them remained very, very low. Some did have a very nice level of antibody response. And then the majority of them were somewhere in the middle in this sort of, we're not really sure what this means range. Again, those on anti-metabolites had a lower chance of getting an antibody response than those on other types of immunosuppression. Those further out from transplant had a higher chance of getting an antibody response. The age thing kind of disappeared, and the Moderna versus Pfizer thing, while slight, basically also disappeared. And so that was good to know that, there wasn't really this sort of, top choice vaccine, mRNA vaccine approach for transplant patients, but those who got Pfizer and Moderna seem to do pretty equally after the 2 doses. We did look specifically in people who had thoracic transplants. So among heart transplant patients, they kind of looked like the whole population. About 44% had no response to the second dose. Lung transplant patients were even sort of worse off, maybe you might call it, with 58% having no response to the full vaccination, presumably because of more aggressive use of immunosuppression, and then maybe something related to the organ that we don't quite biologically understand yet. Those who had liver transplants actually were in a much better situation, where only 19% of them were non-responders, meaning that 80% of them did show an antibody response. But again, as you see, there are some who are sort of off the charts, as you might call it, but a lot who are sort of somewhere there in the middle, in that range where we don't have a great understanding of what means. And so, while a rosier picture for liver transplant recipients, certainly not anywhere near the same as people who are not transplant recipients. We have looked using some fancy artificial intelligence, machine learning exploration to take all of the information that we have about people and to look to see what is important in predicting who responds well to the vaccine. Being on MMF is really an important variable. How long you are since the transplant's an important variable. Age is an important variable. And you see those, like, we can quantify how important they are. And those 3 are sort of the most important. And then even among the rest of those top 10, you see the importance is actually very, very low compared to the importance of those first 3 variables. And so this is sort of the independent impact. Yes, there's a little bit of impact if you had a liver versus a lung transplant. There's a little bit of impact based on the vaccine platform that you got, et cetera, et cetera. But the biggest impacts are MMF, time since transplant, and age, just like we saw in the first dose paper. Obviously, our study was followed up by dozens of confirmatory studies in all sorts of different transplant populations. These are the papers that were published as of end of July. I'm sure this list is even longer now, but a lot of groups have looked at their own patients, various organs received, and various vaccines that they got, and found quite similar, confirmation that a solid majority of transplant patients will have some issue with antibody response to the vaccines. So again, highly motivating us to try to figure out what to do. One might say, well, what we were measuring up until that point was just antibody levels. What does really an antibody level mean? Does it correlate with other things that are more clinically important? And the 2 things sort of along this pathway, like there's antibodies, which is the thing you can measure, and then there is neutralization, which is sort of taking your blood and seeing if it can actually kill COVID. And there are actually live virus neutralization assays. We have a lab that has actual COVID, has the Delta variant and the Alpha variant and the wild type, et cetera. They have those actual viruses, and they throw your blood in with those viruses, and they see if your blood can kill those viruses. And those are neutralization assays. And this is elegant work from Andrew Caraba in his lab, looking at the correlation between antibodies that we measure and neutralization activity. And you can see once you cross sort of this threshold, which is the threshold that we've been calling going from low positive to high positive. Once you cross into high positive, the more antibodies you have, the more neutralization you have of all of the different types of virus that we're aware of. And so that's really important. That gives us this, we're not just looking at these random numbers of antibody levels, but that the antibody levels actually probably mean something, even in transplant patients. Now, this work is not in transplant patients, but this was from the original Moderna randomized trial where they looked at antibody levels, then they looked at neutralization titers, and then they looked to see who actually got COVID infections. So correlating with we call it a correlative protection kind of study. And what they found was that the antibody level that was measured, so the spike IgG, that's the antibody level, and then neutralization levels correlated with actual risk of COVID-19. So for every 10-fold increase in the given marker that they were looking at, there was a dramatic decrease in the amount of actual COVID infections that people saw, the number of breakthrough infections that people saw. And so at least in people with normal immune systems, this indicates to us that higher antibodies means more neutralization, also means more clinical protection. The thing missing here that we're working on, but may be very, very difficult for us to ever directly study, is does that also count for transplant patients, and at what point are transplant patients protected? Because the difference is we can measure the antibodies, but there's a whole T cell component that's necessary for immunity, both early immunity and late immunity. And that T cell component is fully functional in people with normal immune systems and is the thing we actually suppress in people who are transplant patients, right? Like your regular run-of-the-mill clinical rejection is not an antibody rejection. It's a T cell mediated rejection. So, everybody on this call who has a transplant is on some sort of medication to block your T cells. And the problem is we don't have good ways of measuring those T cells right now. We can't, we would have to fully study the T cell repertoire and T cell activation and T cell metabolomics, and all of those things are incredibly complicated, and we don't have data on that. And so we always have to think in the back of our minds, well, transplant patients are different because they're in some way this T cell system is not as fully functional as it is in people with normal immune systems. But still, this shows us that the thing we were seeing in transplant patients, which was low antibody levels, correlates with things like neutralization, even of the variants of concern. And then we gathered data from 17 hospitals and really proved to ourselves that there actually is a clinical problem as well. That the problem is not just that transplant patients have low antibody levels, but that transplant patients, when fully vaccinated, have more breakthrough infections and more severe breakthrough infections. This is data on 18,000 transplant recipients. I will say it's a bit scary, but it's important to know that when you compare fully vaccinated transplant patients with fully vaccinated people in the general population as studied by the CDC, the risk of a breakthrough infection in a transplant patient is 82 times higher, and the risk of a breakthrough infection associated with hospitalization or death is 485 times higher. So the things you hear CDC saying, like it's safe to do this if you're vaccinated, it's safe to do that if you're vaccinated, even if you get a breakthrough infection, it'll be mild, you probably won't even be hospitalized. Those things don't apply to transplant patients at all. In fact, in this study of 18,000 transplant patients, the mortality of a breakthrough infection was 9%. That is not the mortality of a breakthrough infection in the general population. And so we need to continue to remember that there's responses, immune responses to the vaccines that are not optimal in transplant patients. Well, what groups of transplant patients don't do as well? Those taking Bela, and if you are taking it, you know who you are. And if you're not taking it, then you're probably like, what is Bela? But there is a transplant medication that some patients take called belatacib that because of the way it works, we see almost no antibody response to the vaccines in anybody who takes Bela, whether it's 1 dose, 2 doses, 3 doses, et cetera. So there seems to be a small group of transplant patients who are almost completely refractory to vaccine-based immunity. And we'll talk a little bit later about what can be done with people who don't get a good vaccine-based immunity. People who got the J&J vaccine, unfortunately, transplant patients did not have a good response to the J&J vaccine at all. You're looking at, in orange are the antibody levels of people who got the J&J. In blue, the mRNA. mRNA is not great, but J&J is way worse. So after a full J&J series, which is 1 dose, 80% of transplant patients had no detectable antibody whatsoever. And those who did had a very, very low level. You don't see any orange along the spectrum of what we would consider to be encouraging antibody results. And so this is obviously problematic. Transplant patients who got J&J really need to be talking to their doctors, getting boosters with either J&J or mRNA vaccines or something like that. And as we know, CDC has kind of left this hole of what do people, even in the general population, what do people who got J&J vaccines do for boosters and things like that? So anyone who got the J&J as their primary vaccination really needs to talk to their medical team about figuring out how to get better protection. Interestingly, pediatric patients have better antibody responses than adult patients. This is, maybe a tiny bit of good news that we've heard in this pandemic for transplant patients. But after 2 doses, 73% of pediatric patients had an antibody response, and the titers were quite high. And so there is some possibility for getting good immune reaction in pediatric patients. The other group that does quite well in terms of an antibody response are those who are convalescent. And what I mean by that is people who had COVID in the past. So a transplant patient who had COVID, who then gets an mRNA vaccination, even after the first dose, 90% of them already had detectable antibodies among people who had prior COVID. So the combination of having had a prior infection, remember, during that infection, we probably reduced your immunosuppression. That gives your immune system a chance to respond to that infection. Your immune system also responds quite broadly to that infection. And then we add the vaccine on top of that, and then you can get a really good antibody response. Although I do not recommend getting COVID as a way to build immunity to COVID. That is a very, very dangerous thing in transplant patients. But those who got it and survived from it and then got vaccinated have very, very high antibody levels, which is good because nobody wants to get that again. So knowing that the 2-dose series was, quite inadequate for transplant patients, some people just started going to get 3rd doses. And, before this was approved in the United States, people would just go to the pharmacy and either tell the pharmacy, I'm a transplant patient, I had no response to 2 doses, I checked my antibodies, they're negative, I want a 3rd dose, and the pharmacy would allow it. Or they would just go to a new pharmacy and say, I want to get vaccinated, and no questions were asked, or maybe questions were asked, and who knows how this happened, but people started getting 3rd doses. And people in our study started getting 3rd doses. So we started looking at the response to 3rd doses. And indeed, actually, the response to 3rd doses was quite encouraging. And in our first paper that we published in June, which is the paper that sort of motivated discussions of the FDA and CDC, because we sent the paper to the FDA and CDC, we showed that if you started low positive before your 3rd dose, and remember, those who were low positive did not have good neutralization capability, then we could boost you to high positive with a 3rd dose. But even if you started completely negative, a solid 1/3 of those boosted to either low positive or high positive with a 3rd dose. And these are some updated data that we looked at a month ago. And with more patients, we're able to see basically still the same thing. If you start low positive, you're going to boost very nicely. If you start negative, about half of the people are going to get a nice boost with a third dose. And then after this came out, there were reports from France where third doses became allowable even as early as April. And there was a randomized trial in Canada that looked at third doses and compared them to placebo. And obviously, third doses work quite well in transplant patients. You can look at the antibody titers. So here are on the y-axis, you see antibody levels going from negative all the way up to, so the Roche assay right now, the LabCorp assay maxes out at 2,500. So anyone who's there sort of we can't measure anything higher than that using that assay. And the orange ones are the ones who started low positive. The blue ones are the ones who started negative. And as you see, all orange who started low positive end up above this line and are in the group that we would now categorize as high positive, whatever high positive means. And then the ones who started negative, even then, a lot of them became positive as well. And these highly encouraging data are the ones that encouraged the CDC and the FDA back in August to make the change to allow and encourage those who are immunosuppressed, like transplant patients, to go get third doses. And I'm assuming that probably the majority of the people on this call have already gone and done that. Now, remember that, sure, yeah, there's a lot of encouragement in the people who sort of skyrocketed to the 2,500 plus range, but there are a bunch of people in this low positive range, which we know doesn't have much neutralization capability. And even in this kind of low, high positive range, there are a bunch of people in that range who still, after 3 doses, did not achieve what we would guess would be a lot of immune protection. And, again, just like before third doses were authorized, people were getting third doses, people are also getting fourth doses. And we recently published our first series of 18 patients who got the fourth dose. And quite similar to the third dose, those who were low positive boosted to high positive, and those who started negative, half of them boosted as well. Of course, this is a nice demonstration of if at first you don't succeed, try again. But how many times are you going to try? Einstein said insanity is doing the same thing over and over again and expecting a different result. I get questions for people. I'm negative after 4 doses. Should I get a 5th dose? We just don't know. And there's, obviously there's probably, in most people, there's probably something happening in the immune system with that 2nd, 3rd, 4th dose that we're just not seeing in terms of antibodies. And at some point you hit this threshold and now all of a sudden you can make antibodies. And it may be that some people need a 5th dose, and it may be that some people need a 4th dose, but these are really unanswered scientific questions. But fortunately, even as early as March in our first JAMA paper, Anthony Fauci has taken a lot of notice to what we have published in the transplant world and in other immunocompromised patients as well. Even as early as March, he was presenting the findings about transplant patients to the White House briefings, and the CDC was aware and the FDA was aware, and that's great. He's been a really important ally in making sure that the nation knew that immunocompromised people were not seeing the same level of protection as everybody else. And he has funded us now to do a few really important studies, which are coming soon. One of them is a randomized trial to answer the question, so let's say you got your 3 shots or something and you still have very low or negative antibodies. Do we just give you a 4th shot, or is it time to reduce your immunosuppression? So obviously there are risks of reducing your immunosuppression, but perhaps in some patients, those risks would be outweighed by the benefits of getting a much better immune response. And we are about to launch a national randomized trial, multi-center randomized trial, where we will actually be, in a very formulaic and scientific way, reducing some people's immunosuppression who are randomized to that arm or not reducing their immunosuppression and giving them a booster to see, is there really a difference? Because, if there's no difference, if the booster works the same way, regardless of what we do with your immunosuppression, then it's dangerous to mess with your immunosuppression. If the booster works way better, if we just do a small decrease, temporary decrease to your immunosuppression, then for the people for whom that's safe, that's probably a very good way of achieving immunity. So that's one study. And then shortly thereafter, we will also be launching a study looking at homologous versus heterologous boosting. And what I mean by that is, do you boost with the same platform that you got? So you got an mRNA and then you get another mRNA, or is it better to change platforms and go from an mRNA and then get a booster with the Johnson & Johnson or something like that? And we're going to answer that in a randomized trial as well. Those two things, should I change my immunosuppression during boosting, and should I get boosted with the same platform or a different platform? We do not have answers for right now, and that's why we're doing these trials. And so, hopefully we'll have answers. Again, as with randomized trials go, we're not going to have answers at the time that you are urgently wanting these answers, but in 3 to 6 months, we'll have really good answers, so that when the next set of boosters comes out, and when the next variant comes out, and then you need a vaccine for that variant, or when the next virus comes out and we need to understand those things, we will have learned those things from this early part of this pandemic as well. So from a scientific standpoint, what do the data say? Well, the data say that the vaccines have a good safety profile in solid organ transplant recipients. That's really important to know. So get vaccinated. There is less anti-spike antibody responses after vaccination in transplant patients than in the general population. It's better in people who've had a liver transplant, better in pediatric patients, and better in convalescent patients, meaning people who had COVID in the past. It's worse in patients taking anti-metabolites. It's worse in people taking Bella. It's worse in people whose primary vaccine was the Johnson & Johnson platform. We have data in transplant patients correlating antibody levels to neutralization, even of the variants of concern, and in the general population, correlating neutralization to clinical protection of actual breakthrough infections. There is a substantially higher rate of breakthrough infections in transplant patients. I will say it should make you feel a bit better that those data came from a time where the word wasn't really out to transplant patients that you are potentially in trouble and you need to be careful. I think today we don't see that many breakthrough infections in transplant patients because transplant patients are wearing masks and distancing and avoiding all of those things that you need to avoid now because you know that the vaccines don't work that well yet. There is some improvement with booster doses, so that's encouraging, but some will need other immunity strategies. So, rather than a active vaccine immunity, so, vaccines activating your immune system, there are ways to get passive immunity like monoclonal antibodies, and I'm sure that we'll talk in great detail about those things as well. So what are the implications for transplant patients? Now, this is sort of leaving the science and saying, okay, I'm a scientist, but I'm also a doctor, and I have to give people advice today. And my advice can't be wait 6 months for the randomized trial, but my advice has to be, whatever, based on what we know today, what are we going to tell you today? Just like 3 months ago, based on what we knew 3 months ago, we had to give people advice. So what advice is reasonable to give? Well, in general, transplant patients should get vaccinated. Every society has said that. That's pretty easy. In general, the overarching recommendation is that transplant patients should get that third dose that is now available in the United States. It's recommended by the CDC. It's approved by the FDA. It's in use in Canada. It's in use in Israel and France. And there have been now probably tens of thousands of transplant patients who've gotten these doses, and it seems to be safe. However, do involve your medical team, particularly as you're going down that third dose route. If you're thinking about getting an antibody level, I will say that, the FDA says, or the CDC says, we should not be antibody testing everybody. And I think that's true, but antibody tests can be sometimes useful in certain scenarios for certain people, but they need interpretation, and that's just part of what we do. Just like if all we did was a creatinine on a kidney patient, we wouldn't know the whole story. If all we did is an antibody level on somebody, we don't know the whole story, but your doctors know you and what makes you different, as a transplant patient, and what makes you unique as, whatever immunosuppression you take and what your history is with donor-specific antibodies and HLA mismatches, and all your doctors know you well and can help sort of put into perspective all of these things. Do create a protective bubble. So try to get everyone around you vaccinated. The more people around you who are vaccinated, the more you have sort of your own micro herd immunity. But act unvaccinated. Do not do those things that the CDC says, oh, sure, don't worry about it. You can go and do these things. I have a normal immune system, and I'm not eating indoors at restaurants because I don't feel comfortable eating indoors at restaurants. And certainly transplant patients should not feel that level of comfort either. So do protect yourself as much as you possibly can. Wear masks indoors around people that you don't know. Try to avoid these sort of crowded indoor situations. Try to distance yourself from people. You don't have to hide in your house, but like we know enough today about what is safe to do and what is unsafe to do. And in fact, if you look at the CDC guidelines for unvaccinated people, there are things that are green, that they're like, yes, going outdoors to a park where you're not crowded by a lot of people, that's safe. There are things that are red, like, being unmasked for 2 hours at a bar or a restaurant or something like that. And there are things in between. So sort of familiarize yourself with this risk, with the differences in risks of different activities, and then make sure, you sort of are on the safer side of things. When a restriction relaxes, I've always told transplant patients this, but don't be the first one to relax that restriction. Let everybody else be the experiments. And if a restriction was relaxed and a month later there isn't a huge wave of surge of new COVID, then maybe you can start to relax that restriction as well. But don't be the first one. Let people with better immune protection be those first people. Monoclonal antibodies are something that we hear about a lot, more lately than before, which is good because these things work really well. Monoclonal antibodies are definitely a mainstay of early treatment. So if anybody that especially a transplant patient, gets COVID, tests positive for COVID, they should definitely talk to their doctors about monoclonal antibodies. There's also post-exposure prophylaxis. So if you were exposed, but you don't necessarily know if you got COVID or not, let your doctors know, and there are ways to get post-exposure prophylaxis as well. And we are working on trials, and there is a growing availability of pre-exposure prophylaxis as well. So for example, if you're on Bella, we know vaccines won't work for you. Ideally, we need to get you some sort of prophylaxis before you even get exposed, let alone after you got exposed. And those things, that takes me to my last point, which is that things keep changing. Every week we get new FDA things, new CDC things, new things are approved, new changes happen. Do your best to stay up to date. I mean, obviously you're part of an incredible group of patients and other experts who can help you stay up to date. We try to, give the patients who are seen at Hopkins as much up-to-date information as we possibly can, but it's hard. And it takes active work, and something we told you 6 months ago might not be valid next week. And that's really important to know. And it drives people crazy. And they say, well, the scientists keep changing their mind. And it's not the scientists keep changing their mind. It's that science keeps evolving, and then we keep making better recommendations based on the new evolution of that science. And I think that the biggest thing you'll see in the next few weeks is an evolution of monoclonal antibodies and the role of monoclonal antibodies, particularly for transplant patients. So keep an eye out on that. I will just end again with a great acknowledgement to the 100 or so people that are in my research group and who've done tremendous work in the last 2 years to understand COVID in transplant patients and vaccines, and all of the ongoing work that we have happening, and all of this stuff that I presented to you came from this really, really hardworking group of people who, you know, when the pandemic started, they decided we're going to work a lot harder than we've ever worked before to help transplant patients. So that is the formal presentation. And then I'm more than happy to take as many questions as we can possibly answer in the next 15 or 20-ish minutes. And I'm scrolling through the chat and a bit overwhelmed by that, but I hope that our gracious hosts have been keeping up with it and have pulled the questions that seem to be the hottest topics.
It's very hard to keep up with the chat. I was overwhelmed myself trying to listen to you and go through the chat at the same time. Thank you, Dr. Segev. We did have a lot of people ask about going back to the office now. People are going back to the office. They need to wear a mask while in the hallways, not at their desk. How safe is that? How about on a plane, on the actual plane, not in the airport? How safe is that? And then the holidays, tips for handling the holidays, those three things.
Yeah. So this is all a spectrum. And some of this depends on sort of where you live your life in terms of risk taking. I'm a rock climber. I climb mountains. I take risks in doing that. I'm obviously safer not to do that. And we all sort of have our own levels of risk tolerance. And I think that the key is to be aware of what is, you know, where on the spectrum is the activity that you're doing, and then also where on the spectrum are you in terms of your risk, like the protection that you actually have, and your risk if you should actually get COVID. Because some folks, if they get COVID, are probably not going to do well at all, and some folks are probably in a lot better shape from a comorbidity standpoint and need to worry slightly less about getting COVID than others. And I think those things, those are really important to talk to your doctors about. Sort of like ask your doctor, not is it safe or unsafe, but like, where am I on the spectrum of like, if I should happen to get COVID, how bad would it be for me? Where am I on the spectrum of how protected I am? I mean, if you're a Bella patient and you've gotten 2 doses or 3 doses of the vaccine and you check your antibodies and they're negative, you're not very well protected. In fact, if you're any transplant patient and you check your antibodies and they're negative or they're very, very low on in the range, you're probably also not very protected. So you need to be way more careful than somebody who, isn't on MMF, got a liver transplant 7 years ago, got 3 doses, is greater than 2,500 on the LabCorp assay. Yeah, you may have some reduced protection because of T-cell immunity and things like that, but you're obviously better protected than somebody who has 0. And so consider those things. Remember, before we had vaccines, masks and distancing was everything. Like if we were in the hospital, I was operating in the operating room, standing shoulder to shoulder with a team of 10 people prior to vaccines. And we were wearing masks in a well-ventilated area, that's sort of professionally ventilated. And there were not breakthroughs of COVID in the hospital. Like, so masks work and they work really well. And particularly, the better masks. And so I think if you have to go back to the office, then for sure, do everything you possibly can to protect yourself while you are there. And we know that the best thing you can do to protect yourself while you're in the office is to wear a mask as much of the time as you possibly can. Are we going to be wearing masks for the rest of our lives? Maybe in some instances, maybe in some situations, maybe as this waxes and wanes, we'll in a couple months, there'll be no cases anywhere. And, we'll be able to be a little bit more cavalier about the masks. Then we'll watch the curve go back up with another wave and we'll be back to wearing masks, et cetera. I have to say, I've spent the last 15 years of my career probably 6 times a year in Asia giving lectures, and people wear masks in Asia because they had the original SARS. And if you go on the subway in Asia, half the people are wearing masks anyway, not because they're transplant patients, but because like that's become kind of part of the culture of, I don't want to breathe 150 people's air on this crowded subway car. So I think we'll have some cultural changes that will happen, and people will, in particularly high risk situations, will probably be wearing masks more often. And when I say we, I mean not just transplant patients, I mean everybody who sort of doesn't want to get sick. But, you know, I think for the time being, until we really get a handle on this, just be careful indoors. Like indoors is when you're at risk. Indoors with a big group of people is when you're at risk. Indoors with people who are not wearing masks is when you're at risk. So, you know, wear a mask in the halls, wear a mask if you're meeting with people in your office. If you've got food to eat or drink to consume, try to go outside to do it. Even, you know, if it's like, do I eat inside the restaurant or in a dining room in my office where everybody's eating unmasked and stuff? Maybe eat in your own office where there aren't people around you, or take the food outside. Like when you take your mask off, try to be outside when you do that, etc. The nice thing about travel is that on airplanes, everybody, for the most part, is wearing a mask and there's good ventilation. So, you know, we've, even at early on, before we had vaccines, there were not a lot of reports of major transmissions on airplanes because they started requiring masks very, very early on airplanes. So, you know, if you want to go visit your vaccinated family who's careful and who isn't going to give you COVID, and your worry is, you know, spending 2 hours on an airplane, you're probably okay, unless you're one of those that has 0 antibodies and is going to get really, really sick and have a very high risk of dying if you get COVID. And then maybe this is not the time to do that. Maybe wait for wave 4 to subside substantially, you know, and find a window where there isn't a lot of infection out there to take a risk like that.
Someone asking, thank you, doctor. Someone asking, should the caregivers or the other household members that are not immunocompromised be getting the booster shot when someone in the household is a transplant? And why hasn't the CDC been advocating for that?
Yeah, it's a great question. And I think the answer is everybody, even with a normal immune system, will eventually need a booster. I've actually written about this. I've started writing some op-eds so that the insights we have are not just limited to medical journals, but are actually out there. And I wrote an op-ed in The Hill that was called "We'll All Need a Booster Eventually," or something like that. I can't remember what I called it. But the premise is that, you know, antibodies wane. Okay, as you can imagine, being somebody who's been studying antibodies now for the last year and somebody who's hypervigilant, I've been even following my own antibody levels after my first dose, my second dose. And, you know, second dose, it started really high, and then it starts to wane, it starts to wane, starts to wane, and you get a third dose and boom, it goes right back up again. So if you're having antibodies, means that you have early immune response, and very aggressive early immune response. So if 2 people go to a restaurant, they're both vaccinated. They both got vaccinated, let's say in March. One got a booster, one didn't, and there is a spread of COVID in that restaurant. The person who just got a booster probably won't get it. And the person who didn't get a booster probably will get it. And they may have, if they have a normal immune system, they may have a super, you know, chill, easy course of COVID, but there's going to be like a 5-day window where they don't know they have it, and then they're spreading it to everybody, and then they can spread it to a transplant patient. So I would definitely say that as soon as anybody around you is eligible for a booster, they should be strongly encouraged to go get a booster. And I think that at this point, you know, again, I say things are changing weekly. I think very soon boosters will be available basically for everyone. And I would consider, so they're saying, for example, you know, if you are on the front lines, or you are, you know, sort of, if you are, part of your life is exposure to people, et cetera, then you're recommended for a booster. You know, they may even be able to make an argument that I'm exposed to transplant patients, and as a result, I need to be more protected and qualify for a booster. I don't know exactly how people can read and interpret the CDC and FDA guidelines, but I would certainly consider somebody who lives with a transplant patient to be as much in need of a booster as somebody who, you know, works at a Starbucks or, you know, works in a hospital or something like that.
Thank you, doctor. A lot of people asking, some people, it appears, have had a fourth shot. Should they continue to get shots because they're doing the antibody tests and not getting good results, having no antibodies?
Yeah, it's a good question. I mean, every time you get a shot, there's some risk of something, right? There's a risk that you'll activate your immune system and that your immune system will harm your transplanted organ. So every time you do that, there's some tiny risk. There's also a risk of what's called tolerance, which is that your body will get so used to seeing the shots that it won't care about the shot anymore, and you won't be able to activate your immune system. So I think if you've gotten 3 shots and you are still negative, there is an issue there with your immune system that we need to better understand rather than just to continue to punch at the wall. I think, you know, that is a discussion you need to have with your medical team. Consider yourself for this randomized trial that's about to come out, where instead of just getting the booster, you might have your immunosuppression reduced, or you might get a booster of a different platform or something like that. Or you may be in one of those categories that you're just not going to have a good response to a vaccine and you need monoclonal protection or something like that. But I would say if you know you have failed 3 shots, and especially if you know you have failed 4 shots, like, continuing to just do the same thing is probably not going to be the wisest move, at least without talking it over with your transplant team, because, you know, you do reach a point of sort of diminishing returns with those, at least from what we know. Now, our trial may prove completely otherwise, but at least from what we know and sort of what the biology would indicate.
Thank you, doctor. A lot of people talking about the antibody tests. There are different types. Is there a specific one that is preferred for transplant recipients?
So the one we use in our trial, so what I tell people is, if you're going to get an antibody test, get an antibody test that people have used a lot in the kind of patient you are. And in transplant patients, we have studied antibody tests using the Roche platform, which is the one you can get at LabCorp, walk in, no prescription or anything like that. It's a semi-quantitative anti-spike antibody. You don't want the qualitative that just tells you yes or no, because those are not very useful. So it's a semi-quantitative. It gives you a number. It caps out at 2,500. And we have a sense of what that means. We've tried to correlate it with neutralization assays. We've looked at the spectrum in transplant patients and things like that. But again, if you're going to do that, make sure you have a plan for what you're going to do based on what it shows, right? So an easy example that I can give you is if work says, okay, everyone's vaccinated now, you need to come back to work in person, and you're worried, and you would rather try to make a very compelling argument that you want to work from home, and you tell them, but I'm a transplant patient. They say, well, whatever, that's not compelling to us. And you go and you get an antibody test and it's negative. Then you can send it to them and you can say, look, my antibody test is negative. I have no protection. I cannot get protected. You please do everything you possibly can to see that I can work remotely. And I've definitely heard success stories from that. So in that regard, an antibody test is actually quite valuable. If you're asking yourself, you know, is it safe for me to do certain activities? Well, an antibody test will give you some information. It'll tell you, are you off the charts? Are you somewhere in sort of no man's land where we don't really know what it means? Or are you absolutely negative? And that may help you make certain decisions, but don't just get an antibody test without a plan for how it's going to change the way you think about things. And certainly don't do it with your, without sort of interacting with your medical team as well.
Thank you. This will have to be the last question. I know there's many more questions, but Dr. Segev has to leave. If a transplant patient gets COVID? Are there successful treatments?
Yeah, so anybody who gets COVID today, especially a transplant patient, as soon as you test positive, and I can tell you at our house, we have a bunch of the home tests around, because if we had anyway are symptomatic, or we heard that we went to a thing and somebody had COVID and we might have been exposed, we immediately take home self-test. So, be vigilant about getting tested. And if you have a positive test, immediately let your medical team know and ask about monoclonal antibodies. You can only use those early. Once you're hospitalized and you start getting sick, you cannot use those anymore. So ask about that early, and make sure that that your medical team hears the word monoclonals in your conversation with them, and can tell you about availability and what criteria you need to meet, et cetera, and that they know as early as that you possibly can tell them that you ended up COVID positive. And with good early treatment, the outcomes are much more encouraging than they were in the past.
Super. Thank you. We really do appreciate you joining us today. Thank you so much for your presentation. You could have stayed here forever and the questions would have just kept coming, I'm sure. So thank you for your expertise and your time very much. Appreciated.
Oh, you're very
you.
welcome. It's a pleasure to join you all. Nice to see so many faces and so many questions. And I know I wish I could stay for another 4 hours and answer all the questions. Hopefully you'll be able to get additional resources and get more answers. And please do, sort of talk to your medical teams. And, we're all sort of sharing information now. So maybe a medical team doesn't know about some of the information that we've published because it was last week. So bring people up to speed, continue to have these conversations. Be careful out there. But don't lose hope. We're learning so much, and things are getting so much better. And I would say, the outlook for what is life going to be like in 2022 and beyond for a transplant patient compared to 6 months ago is just so much better. We know so much more. We're so much better at treating this. We're so much better at protecting you. We're going to be even better once these monoclonal trials come out, once the randomized trials come out on these vaccines, and just, hang in there, and it'll get better. So that's my end.
Okay, thank you.
And Dr. Dorry,
right.
This is Marty. I just wanted to say thanks again for attending our meeting today. And I wanted to thank everyone that took their time this morning to get out of bed and join Dr. Dorry and us for this important meeting. I want to remind everyone to check our website at www.triomaryland.org. You will find a lot of these sessions on that website from the conference and that. And Dr. Dorry's speech will be on there in approximately a week. I also want to mention we have a very active Facebook page for people who are not aware of that. And we want to wish everyone a great rest of the fall weekend, and stay safe out there.
The questions just keep coming in, Dr. Segev. I feel terrible. Thank you. Bye-bye.
Thank you, Doctor.
Bye, Al.